Hello, my name's Paul Robinson. I'm the author of the Recovering from Hypothyroidism series of books, which includes the Thyroid Patient's Manual, Recovering with T3, and the CT3M Handbook. I thought I'd make a short video based on my experience of working with patients, and I've been doing that for the last 16 or 17 years now, a long time. A lot of that work is done online. And I have done and still do some one-to-one coaching as well with individuals over Zoom. And I've made some observations over the years. And I think for me, there are about 7 or 8 different categories that I find that patients usually fit into. And I thought I'd explore those with you, talk about them, because I thought some of you might find it interesting. You can even see if you think you fit into one of these categories as well. I'm talking about categories in terms of what's going on with the thyroid treatment or related issues. So I've got a little crib sheet over here, which I've stuck up just to remind myself what I'm talking about. I'll start out with people on T4. And one of the biggest problems I see where from the treatment that people have been given is that they're on T4, they appear to be converting okay, but they never get well. They're still hypothyroid. And often that is simply because the doctors have not increased the T4 medication high enough. And they have not done that usually because of TSH. I'm sure you've all heard this before, but TSH is so often used to limit how much treatment someone is getting. And I think this is based largely on doctors' understanding of hyperthyroidism, where there is an overactive thyroid gland, which is producing too much of FT3, and too much FT4, but also TSH is suppressed. So doctors and endos see low TSH and they think, oh, that means hyperthyroidism, but it doesn't. On thyroid treatment, it's a completely different situation. On thyroid treatment, generally speaking, the individual doesn't convert T4 to T3 as well as they used to. They usually have higher T4 and lower T3 than they had when they were well. And often TSH has to get suppressed, has to be put close to 0 or at 0 for the person to get enough FT4 in order to get enough FT3. And it's FT3. T3 is the active hormone. The people generally need enough T3 in order to get over their hypothyroid symptoms. So that's one big category. And it happens so often. I see people on T4 and they come and talk to me and they say, well, I need T3. And I say, well, okay, so look at your labs. And I say, well, why wasn't the T4 dose increased? Why can't you get more? And they'll say the doctor won't do it because TSH gets too low. And that's just the wrong answer. So that's one big category. Another one on T4 treatment, generally speaking, is when TSH is either low or is high. And FT4 is very high. And FT3 still doesn't get there. It's still too low. It might be in the range. And doctors, again, are often happy to say, FT3 is in range, your numbers are okay, you're fine, it's not a thyroid issue. But of course, T3 needs to be in the right place in the range for every individual. And often that's much higher up the range. And if you can't get it there with a high dose of T4, then simply there's a conversion issue there. And that T4 medication, levothyroxine, is just not working. And you need something else. You need to have less T4 usually and some T3 added in. So that's a second big category. Then we get a third category where people actually are on combination. They're on T4 meds and they're on some T3 meds. And they're still not well. They're still hypothyroid. And they're not, again, they haven't got enough FT3 for them to make them well. Or they've got a reasonable level of FT3, but they've got very high reverse T3. And T4 medication, which goes into free T4, can go either from free T4 into free T3, or it can go into reverse T3. And you'll get some amount of FT4 and some amount of reverse T3. And some people they simply cannot get enough free T3 from that combination. And what then needs to happen is the T4 meds need to be really reduced and the T3 medication needs to be brought up. And again, that's another issue because doctors tend not to, if they prescribe T3 at all, they tend to want to prescribe very small amounts of it. So that's another big category. Fourth category here is people that are on, could be on combination again, but it's so clear that the T4 is converting absolutely dreadfully. With even on small amounts of T4, they're getting very high reverse T3, and they're simply not getting the free T4 from it. And those people really need to be on T3 mostly treatment or T3 only treatment. Now, that's not such a big category in terms of numbers of percentage of people, but it still affects an awful lot of people. And this is where this situation, sadly, is very, very poorly treated. Doctors generally do not want people to be mostly on T3 treatment, but it's a real issue for those people that need it, and they simply can't convert very well. And the conversion issues can happen for all kinds of reasons. Loss of thyroid tissue is a big one, where people have lost the thyroid gland, and which is the most important converter of T4 to T3 in the body. Other issues can be genetic issues with the deiodinase enzymes. But for whatever reason, it's essential that those people get on T3 mostly or T3 only. So that's another big category. Fifth category is cortisol. Cortisol works, that's cortisol there, and this is T3. They're partners inside the cells, and they have to be balanced at good levels. So I often suggest to people that they get their saliva cortisol test done and a 9 a.m. Morning blood cortisol done. I like to have both, because sometimes you can get inconsistencies with results, and that can tell you something that's something else that's wrong. But it's very important to get it tested. But if cortisol's too low, then the thyroid hormone won't work properly. Even the active T3, even if your free T3 level's good, it won't work well if the cortisol's too low. And if the cortisol's very low, the person then tends to have adrenaline that's made in compensation, and that gives them high heart rate and all sorts of issues tolerating any T3. So that's a big issue as well. Another big category, just spoken to someone on a one-to-one Zoom this morning about this, is something else is going on. Could be low B12, it could be low iron, could be low ferritin, could be another issue, something that's basically preventing the thyroid hormone from working properly, or causing symptoms that are similar to hypothyroidism. And B12 is a classic one, because doctors again don't know how to diagnose or treat it properly. Often someone's taking a multivitamin, which really confuses things, because B12 is the only vitamin that can circulate around the body in the bloodstream for 4 months after taking multivitamin or anything with B12 in it. And it can make the blood tests look excellent. Even active B12 can make it look excellent, even though the cellular B12 is actually very low. So I often look at other issues just to make sure there's nothing else in play. And the person I spoke to this morning is now on B12 injections, which is the most effective treatment, and it's working wonders for her. So that's another big category. The last category I'm going to talk about is when it's and I don't get many of these people. I probably had about, in terms of doing one-to-one coaching on Zoom, I probably had about 3 of these in the last 5 years. So it's very unusual. It's when there's something really deeply unusual going on that is beyond thyroid, cortisol, the basic vitamins and minerals, an unusual condition that even I can't fathom. And I've had a few of those, but not very many. And it can happen to anybody really. Anybody who's doing any coaching or consult work, and doctors struggle with these types of people as well. It's unfortunate, but sometimes I do get stumped, and it's not very common that it happens, but that's another category there. So those are the kind of cases that I deal with, and the categories I tend to find people are in. One of those, generally speaking. I think as long as you're aware that TSH can be suppressed and it can be okay, and you're on the lookout for poor conversion and free T3 not being in the right place in the range, generally speaking, if you've got a supportive doctor who will prescribe both T4 and T3, then usually you can get that balance straightened out. And another big mistake that doctors make often is if someone's on T4 and they need some T3, they just add the T3 in there, thinking that's going to bump the free T3 level up. And often it doesn't do it at all. It doesn't make any difference, because all that does is make the T4, FT4, convert to more reverse T3 and less free T3. So often you need to lower the T4 meds and as you increase the T3 meds. So that's it. It's a short video. I thought it'd be interesting to share it. The other thing I'm going to mention is that these are pre-release copies, but these are my books in hardback, and they look absolutely fantastic. They look really, really good. And they're going to be out within a couple of weeks. And sometime when they are out, I'll put a blog post out, letting people know that they're there. But I thought I'd mention them now because they've just turned up in the post. So I've been checking them out, making sure they look as good as I thought they would, and they do. Okay, so that's it. I've had a busy morning. Just done work with a client. I've done this now, so I'm gonna go off and have spotted lunch. I'll talk to you again soon. Bye for now.